Okay, so welcome today. We have a talk on male factor, a little bit of a review and an update. As you know, it's an incredibly prevalent contributing factor for couples experiencing infertility.
Mm-hmm.
And I am excited and grateful to have Dr. Natan Bar-Chama to review some of the basics as well as go over the latest research and what we as nurses need to know. So welcome, Dr. Bar-Chama.
Thank you so much. I think this is a unique opportunity. I interact very closely to the nurses here at RMA of NY, and I know how important it is for them, who are the faces to the couples and have a relationship that's unique and that's different than the physicians, to help couples navigate their path to parenthood and understanding male factor infertility and how to relate to it and help couples navigate through that is very important.
Absolutely. And so a little bit about you. This is you. Your website. You're pretty active on Instagram, which is how we were able to find you. But just a little bit about you. You're the director of the Center of Male Reproductive Health at RMA of NY. You're a board-certified urologist and male infertility specialist. For the last 20 years, you've been the director of male reproductive medicine and surgery, and you're on faculty of both the departments of urology and obstetrics and gynecology and reproductive science at Mount Sinai. Your practice is exclusively dedicated to the field of male infertility and sexual medicine, and you published extensively and lectured throughout the world. Annually since 2005, you've been listed in New York Magazine's Best Doctor list of urologists. So we are truly lucky to have you here today.
Thank you for that kind intro. I would say that there are male fertility specialists throughout the United States who are equally trained and capable of helping couples in IVF centers and nurses understand male factor infertility and intervene and appropriately. So I think that finding somebody in your area and that works with your group is really a priority that I cannot overemphasize.
Excellent point. So let's jump in. So the basics. So we're having this talk today because of the prevalence of male factor infertility. Can you give us a brief review of the latest statistics and the prevalence? How is it? Well, we'll start with the prevalence and statistics.
Well, infertility is very common. We understand that about 10% of the population, or 1 out of 10 couples, trying to conceive, as defined by having difficulty for over a 12-month period, suffer from infertility. The important thing to appreciate is that in 1/3 of those cases, the cause and the culprit is the male. And in about another 1/3 of the cases, the identifiable variables contributing to infertility are both on the male and the female side. So in fully 50% of couples who are trying to conceive, there is a male factor component. And I think it's important to understand that male factor infertility, the earlier we diagnose it, the earlier we understand that there is a potential contributing factor on the male side, the easier it is for us to come up with a plan to successfully help that couple achieve a pregnancy.
Makes sense. And how do we define or diagnose? Is it simply just one abnormal semen analysis?
Well, semen analyses fluctuate dramatically. I think that starting off with a semen analysis is critical. What we often find is that people delay, or couples delay, getting that first semen analysis. And I think that it's important to step back and appreciate the fact that if there's a history of surgical, for example, a surgical history of an undescended testicle, or a scrotal trauma, or a medical history of infections or STDs, history of undescended testicles, a history of gonadotoxin usage, such as smoking or marijuana usage. Obviously, if there's a history of steroid abuse, these are all things that if a couple in their discussions identifies, it is important to be proactive and get that initial assessment, which is a semen analysis. Now, fortunately, also, it's important to appreciate that people can begin the process also at home. There are now available sperm home testing devices, which may be easier for men to perform without having to go into the office. But I think the important point here is if there is a risk factor, including lifestyle, for example, if someone is smoking, if someone is overweight, these are all contributing variables that increase the risk of infertility, and getting that initial analysis should happen sooner than later. Getting back to your question, one semen analysis is not adequate. We recommend at least two, with 2 to 3 days of abstinence. And the variables that we look at include concentration, motility, and morphology, which is the shape of the sperm.
Great. I like that you mentioned BMI. Oftentimes nurses may not have met the male partner or meet the male partner late in the process. So I think when we're discussing lifestyle changes, it's so important to just say an elevated BMI category or however we want to discuss it, because that's also something they could be working on.
Again, I'm getting back to the initial point that I was trying to make, is that the nurses that deal with these patients are the ones that often get that information. They get to meet the couple so they can talk about smoking, lifestyle, illicit drug use, and BMI on the male, which sometimes the reproductive endocrinologist doesn't fully address or pick up on in the evaluation. Therefore, have the potential of improving those semen parameters by identifying those problems.
Good point. So before we talk about the semen analysis, which is the main kind of test for male factor. Let's discuss the sperm themselves. Can you discuss the various parts of the sperm, the acrosome, their jobs, etc.?
Sure.
What various defects look like under the microscope?
Yep. So the sperm cell is very different than a normal cell. If you think about your basic anatomy, you're thinking of a cell that has a cytoplasm and a nucleus, and there are different mechanisms or roles that each of those play. The sperm has one simple goal and objective to perform, and that is to transfer the paternal DNA through the female reproductive tract and attach and penetrate the oocyte. And that's, evolution has perfected that. So the sperm head has an acrosome, and under that acrosome are binding sites which enable the sperm to attach to the oocyte. The sperm is compacted, and the DNA is very tightly bound within that sperm head. And then there's the engine, which is the centriole and the midpiece, and then there's a tail. And the tail is, as you can imagine, is really for motility and to get the sperm to travel that long distance. Now, each of those can have, abnormalities. For example, today I saw a patient who was attempting to conceive. He and his wife were attempting to conceive for the last 12 months. And during my discussion with him, he recalled that 20 years ago, when he was having respiratory problems, he had a biopsy of his cilia in the lungs, and he was told that he has immotile cilia syndrome, which is a defect in the cilia, which affects the respiratory tract, but also affects the tail. And so on his semen analysis, for example, the tails don't function. And as a result of that, his motility was 0. So each of these elements has a very important part in getting the paternal DNA attached and to penetrate through into the oocyte. One of the things that I think is important to realize that the binding and the quality of the sperm is very dependent on normal maturation within the testicle, and is very temperature dependent. The reason the testes are outside the body is because it needs to be 2 to 3 degrees cooler. And anything that disrupts that thermal regulation can affect sperm quality, sperm production, and its capability to achieve fertilization. So, for example, sitting in hot tubs. Now there is some literature that supports, loose underwear versus tight underwear. Large veins that are filled with blood that increase the temperature all have an effect on sperm production and quality that can have a negative impact on fertility.
So while we will talk about lifestyle changes, but while we're talking about temperature, you discussed the medical history before. So any diseases which cause a fever, or
yes.
If a male has a fever for a significant period of days, should be discussed with their physician.
So prolonged high temperatures can have an effect on sperm production. And one of the things that's important to realize is that a woman produces an egg every month, but a male production of sperm takes from A to Z approximately 3 months. So therefore, if you've had an insult to the system, such as a prolonged fever, if you sat in hot tubs for an extended period of time, those impacts can affect sperm quality for 1 to 2 cycles, which translates into 3 to 6 months.
So important to know, because when we answer the phone and the husband makes a change, or say has a job where he sits for long periods of time, like a truck driver, or tries to make a change, you don't want to get the repeat semen analysis too soon.
Right. It's very important to understand that distinction, because you put a woman on medication, the expectation is that month she's going to react, produce more eggs, trigger ovulation. We have to switch that expectation when we talk about spermatogenesis, to realize that any intervention, whether it's medication or surgical or nutraceutical intervention, we need at least 1 to 2 cycles for us to gauge the impact. And that, again, as I stated, is about 3 to 6 months.
Makes sense. So you talked about DNA a little bit before, about how it's compacted. Let's talk a little bit more about DNA. And, as nurses, we hear about sperm DNA, DNA integrity, all of these terms. So what does that mean? Like, what damage is it? How do we test for it? What can we do about it? All that good stuff.
So it's very popular for patients when they want to get evaluated at a more basic level. They undergo what's called a DNA fragmentation test or assay. And the name is misleading. The name suggests that we're looking at whether there's mutations or genetic defects or something that would result in an abnormal embryo. And the DNA fragmentation assay does not look at that. The way I like to describe DNA fragmentation is the DNA, as I mentioned, has to be very tightly compacted and coiled. So it's almost like a telephone wire that that is coiled very tightly and precisely, so that when it needs to uncoil, it doesn't get tangled on itself. So that is what's going on here. The DNA has to uncoil properly for it to connect and begin the process of fertilization. So the DNA fragmentation test really assesses whether the DNA is packaged properly. It isn't whether the DNA is damaged in terms of mutations or genetic defects. And if you have DNA fragmentation at a higher percentage than normal, which is above 30%, the chances of achieving a pregnancy naturally or through inseminations is diminished. It doesn't mean it won't happen. It's just not as likely. Whether the DNA fragmentation has an impact on IVF or ICSI, the literature is mixed. Certainly, if the DNA fragmentation is very, very high and a couple has undergone an IVF ICSI cycle and the eggs appear to be good, and the day 2 fertilization or the embryo development was abnormal, and the DNA fragmentation is high, there is some suggestion, therefore, that the DNA fragmentation affected embryo development. But it is not because of the genetics or the DNA per se, but the way it's packaged and able to achieve fertilization.
So two things, I guess, that brings up. So one is this would not be detected by a karyotype. This is a whole different test.
Exactly. That's exactly the point. The point is that a karyotype, for example, Klinefelter syndrome or translocations or Y deletions, is looking at genetic defects. DNA fragmentation assays look at sperm quality and whether it's packaged properly within the sperm head.
And so the second point that I guess that we're still not sure of is maybe the proactive nature of ICSI might be enough to overcome this as opposed to an IUI, but we're not sure yet.
We're not, again, I think that if you look at the American Society for Reproductive Medicine or the prevalent view amongst reproductive endocrinologists is that DNA fragmentation is not going to impact significantly ICSI outcomes. So therefore, at this point, I think one can fairly say that it is a useful test to assess sperm quality. I use it in my practice if someone is smoking to demonstrate to them that it's having an effect. If someone has a large varicocele, if someone has an infection, it might be useful in letting couples know how many inseminations to do before going through IVF. But it isn't one of these tests that categorically will tell you you should not try naturally or do inseminations or IVF.
Makes a lot of sense. So let's talk about the semen analysis a little bit, as it remains our primary test for male factor. Can you briefly review the parameters? Do most clinics use WHO criteria? Maybe discuss what can lead to lower parameters?
Sure. So it's important to, there are World Health, okay, let me rephrase that. The semen analysis is usually the first test that is done to assess male factor fertility. And it is not a simple test to interpret. It looks at many parameters, and one has to really understand how these parameters interact with each other to determine whether really there's a problem or not. So the first thing that you want to assess is whether it was produced properly. Having a semen analysis performed with less than 1 day of abstinence, or having a semen analysis performed with over 7 to 10 days of abstinence will affect the outcome and potentially result in a diagnosis that's not accurate. So the first thing to look at is the abstinence period. Was it done with 2 to 4 days, which is what has been used to assess normal values. The next thing that we look at is volume. Okay, how much fluid is produced? If it's less than 1.5 mLs, first question to ask is, was the sample collected properly? Many men during the initial analysis are nervous and drop or miss the cup, and all of a sudden everyone goes into a frenzy, thinking that there's male factor infertility, when all you have to do is really question the patient, realize he didn't produce it properly, and have him produce a proper sample, and it's fine. So these are things that we encounter all the time, and as nurses, it's very, you may be the first to explain to the patient the results, and those are the questions you might want to ask. The next thing that's looked at is what is the concentration? How much sperm is in the sample? And that's also a tricky number, because the two parameters that are usually reported include million per ml, which is a concentration, and the total count. And the total count should be about 40 million. So let me just throw out some numbers for you. So for example, if someone has a count of 10 million per ml, that's the count, the concentration, and they're told that their count is low because it should be, above 15. In one case, you had 1 ml, and therefore his total count is 1 ml times 10 million per ml, 10 million sperm in the total sample. Well, that's a low concentration because normally it should be above 40 million. Another patient has a volume of 5 mLs, right? But he has the same concentration of 10 million per ml. And he's told that his count is low. And he and his wife are in a panic because, A, they understand that the problem is a low sperm concentration. But in reality, he does not have a low concentration, because if you take 5 mLs, 5, and you multiply it by 10 million per ml, his total count is 50 million. And therefore, his concentration is actually normal. So nurses really need to understand the numbers and how they interact with each other. Before, and sometimes the computer printout or the interpretation that's provided on the report is not accurate. The next thing that's looked at is motility and morphology. And let's start with motility. Motility, as the name implies, is the percentage of sperm that are moving. And you want that to be above 40%. Now, again, you can have somebody with a motility of 35% and a total count of 200 million sperm, and you can have somebody with the same motility of 30% and the total count of 20 million sperm, and that's two very separate pictures. So, the important thing about motility and morphology is that it's a percentage of the total. And you can have a motility that's lower than normal, but the total number of moving sperm in the sample is actually fine. Morphology, there are different ways of doing morphology. Currently, morphology is performed most likely using strict criteria, and that's where they only take 200 sperm. They stain those sperm, they magnify them, and they look at each of those very precisely. And what you're trying to do at that point is identify if there's any defect at all. And what we see here is when you take those 200 sperm and look for any abnormality, in a normal setting, only 4% have normal shape. It's a very low number. But patients and nurses have to appreciate that a normal Kruger morphology is only 4%. And here we fall into we have the same potential pitfall, which is if someone has a strict Kruger morphology of 2%, first of all, patients aren't really aware that normal is 4%. And then again, 2% of 200 million sperm versus 2% of 30 million sperm is a very different number. And what's normal is 2% of 40 million. So the person who, it's 4% of 40 million. So the person who has 2% of 300 million, he has, as an isolated variable, a low morphology. But if you ask the question differently, does he have the normal number of normally shaped sperm in the sample? The answer is yes. So I'm sorry if I'm getting a little, detailed here, but it's so important to interpret the semen analysis properly. What is the total count? And then is the percentage of the total when it comes to motility and morphology truly abnormal, or did just the printout from the computer define a problem when there really isn't one?
Right. I think it's easy to take each of those variables by themselves as opposed to looking at total modal, because then you have to times it by the volume and the motility percentage and the sperm count. Right. And sometimes that ends up being like not done properly.
Look, what I'm seeing is that we see patients who should be evaluated for low count and low motility that are not being evaluated by the male fertility specialists because the technologies are so powerful and the motivation to jump to IVF is high. So those patients who truly have problems sometimes are not being evaluated and assessed to see what we can do to improve things. And the same thing happens on the other side, where couples are coming in and IUIs and IVF failed because the morphology is 3% out of great concentration where we know that that is not an accurate diagnosis and that the individual does not really have a male factor. So, trying to navigate through those two extremes is very important. And I think, as I mentioned, and I'm going to be hopefully repeating as much as I can, very often falls on the shoulders of the nurses who are interacting with the couple.
Makes total sense. One of the statistics that we are often discussing with patients is, let's assume a normal semen analysis or very, very mildly abnormal, one parameter slightly low. But the patient is very anxious to get pregnant quickly. So often we will suggest an insemination over timed intercourse. If that's the case, what would you say the percent chance is greater of getting pregnant per month for a couple? Let's say that they're using Clomid. Let's say that they're using Clomid or an oral ovulation induction aid. Mm-hmm. If they used insemination over timed intercourse, are they doubling their chances? Are they less than doubling their chances? Is there any statistics or research on that?
I think the motivation for doing inseminations is multiple. One of them is to increase your chances of getting pregnant. And I think that if everything is perfectly normal, I tell couples that there's about a 15 to 20% chance of conceiving naturally. And if you bump it up and do intrauterine inseminations, RUIs, you're increasing your chances to 20 or 30%. So I think somewhere between 5 to 15% increase is what you'd expect from trying naturally to insemination and to moving forward with inseminations.
Makes sense. So now we have a patient with an abnormal semen analysis, and we're calling them. And we discussed a couple of points with this, but the first step is making sure that we're interpreting the result properly.
Right. But
let's say that we did. Mm-hmm. What suggestions can we make when the semen analysis is abnormal? And let's assume it's not azoospermic or severely oligospermic, because I know that's a different conversation. Mm-hmm. But maybe mildly oligo. What should we say next?
Well, I think first thing is to highlight that this is only one sample, okay, and that we'd like to repeat that and to get a range. Is the variable consistent, or do we see a fluctuation? That's number one. Number two is to just really identify basic culprits for having a low count, low motility, or poor morphology. And as we discussed, low-hanging fruits such as smoking, drug use, overweight,
alcohol,
hot tubs. Alcohol in moderation is fine, but excessive alcohol. These are all things that, if identified, can intervene, and intervention is effective. And therefore, I think that getting that information right from the beginning may help that couple improve their fertility, especially if the variables are not so severe as you described.
And when should the repeat semen analysis occur?
So I think that there's a misconception here, which is that, yes, we know that sperm production takes 3 months, but the purpose of the second semen analysis is not to see the impact of an intervention, is just to see the variation in that individual. So I recommend that if you have an abnormality, within 2-3 weeks, get a second sample and clearly define the parameters that you need in terms of abstinence. And then based on that, you'll have 2 set of numbers to work with, which gives you a range for that individual.
Yes, very important point. And if during our discussion we find out that they missed the cup or are nervous, that is also something that we might see fixed or reflected in the subsequent semen analysis.
Absolutely, and just there is wide fluctuation. I mean, if you take a normal person, and this has been studied, and you have them produce a sample weekly over an extended period of time, there are times in that individual's profile where the semen analysis is subpar. And so therefore there is within an individual wide variations, fluctuations, and we need to get a handle on that before we commit the couple to assisted reproductive technologies when, that it may not be needed. The important thing to realize is that when we look at these normal semen parameters, it suggests that below those numbers, your chances of getting pregnant are less. But for example, the total count, the average is about 100 million. It's just that when it dips below 40 million as a total concentration, your chances of getting pregnant are diminished.
Makes a lot of sense. So this is a struggle because we want to be able to tell our patients to take a medication or do something different. What, if anything, actually works to improve sperm count? We've talked about lifestyle changes, and we can continue to talk about them. But have any supplements, and I just have one listed here, or in this picture, I'm not saying that this is the good one, but have any been really proven to help?
So I think more fundamental, I think addressing lifestyle is important, and again, as you mentioned, is really there's good data to show that if you are overweight and you lose weight, if you smoke and you stop smoking, that there is going to be an improvement in semen parameters. Getting back to the unique structure of the sperm cell, as it is differentiated from a normal cell, the cytoplasm of a normal cell is where you have the capability to defend the cell, and that's called antioxidant properties. The sperm cell doesn't have a cytoplasm. It's just packaged DNA. It's just a nucleus with a motor attached to the end of it. So things that could harm the cell, free oxygen radicals, for example, are not inherently within the sperm cell structure. It is dependent on the environment, on the seminal fluid, and therefore interventions such as antioxidants or nutritional supplements that can bolster the defense mechanism of the seminal fluid, in some cases where that's diminished, may show improvement and be effective. So we see, for example, published literature where DNA fragmentation, total motile count, and motility are improved with nutraceutical supplements. But again, I think that you have to choose those nutraceutical supplements carefully in terms of production and reliable sources, not to take too much. Too much zinc or any excess of supplements has a negative effect. I think that the literature for nutraceutical and antioxidants in particular is evolving, and there is more support to suggest that in some cases it may be a benefit as well.
So the latest I read on supplements is that they have been shown in some studies to improve sperm parameters. So it's assumptive that they would assume pregnancy rates, but I don't think that the literature has shown an increase in pregnancy rates. Is that still the case?
That is the case. Those studies are very hard to do. For example, in the female field, there's now an emphasis on CoQ10 as a supplement for fertility, for egg and embryo development and maturation. Some of that literature exists also in men. So I think that good data is still lacking. Scientific knowledge or understanding of why this might be of benefit in some cases is there, and some pilot studies suggesting improvement exists, but I think that I do recommend it in my practice, and I think that in conjunction with optimizing lifestyle, which is stop smoking, exercise, lose weight, and if you're doing that, taking some antioxidant therapies is part of that whole program. It's not a treatment necessarily that stands on its own.
So I think I feel like I have a couple of really good points. One is to make sure that we're interpreting the semen analysis properly. Another one is to see the sperm as a product of the whole person, the
Right.
man, and talking about the lifestyle changes and some of the ones that we discussed. To realize that this is an uncomfortable and strange sometimes process for them, and that can affect the production and delivery of the results.
Yep.
Anything else? Any other take-home points that you really want to
Yeah,
emphasize to
I
us?
think certainly the nurses have a personal. The relationship that that nurses have with the couples is unique, and they're able to identify, problems or issues that may have not been picked up by the reproductive endocrinologist, whether it comes to abstinence, collection, erectile dysfunction, the need for, for example, Viagra to optimize the sample and help couples with timed intercourse or delivering samples, producing samples for ART. These are all things that I think the nurses are uniquely suited to help us identify problems and optimize the couple's chances of getting pregnant without having to use the most advanced technologies.
Perfect. Thank you so much for your time. This has been so incredibly helpful, I know, to me, and I've been in the field for a long time, but particularly everybody at all levels. Can you remind us how we can best find you online? I have your website here and your Instagram, and you're pretty active, but I think you just wrote a blog on varicocele, or you wrote a blog on varicocele relatively recently. That's on the website.
Yeah, social media, you can find me there, and certainly RMA of New York is where I practice. And I think, again, getting back to to what we said in the beginning, what I was trained to do is not unique. There are a lot of really excellent, qualified male reproductive specialists throughout the country, and we keep training them, annually, and it's very important for the nurses to really not just know who that person is, but talk to them, and feel free to reach out and ask them questions, and help couples find the right address for expert advice and care. The skill set is a niche one. It's not one that general urologists are often comfortable with or can bring much to the discussion or the treatment component. But the ones that are focused on this can really help the couples. And it's very often that the nurses are the ones that are the proponents in identifying those couples that could benefit from that resource.
Great. Thank you so much. Really appreciate your time.
My pleasure. Thank you.
Thank you. Have a great rest of your day.
You too.